It's an honor to have Dr. Silvia Stacchiotti from the National Cancer Institute of Milan at the Toronto Cardiac Tumor Conference. Dr. Stacchiotti is one of the leaders who have shaped really the treatment of sarcomas worldwide, particularly in ultra-rare sarcomas. Ultra-rare sarcomas, there aren't enough patients to study, and Silvia has been a pioneer in this space, has demonstrated that by organizing a worldwide network of experts and working together, it is possible to understand responses to ultra-rare sarcomas, including tumors of heart, blood vessel, and of vascular origin. Dr. Stacchiotti has spearheaded several trials in this area. Her MO has always been to understand the current status of all of the agents that work in a particular ultra-rare sarcoma, and then move on to prospective studies that stand on a sound footing of data in order to produce excellent outcomes in these particular rare tumors. It's a real pleasure to have you here. I could probably be talking for the rest half hour about her achievements. So without doing that, I will hand off to Dr. Stacchiotti regarding the management of these MDM2 amplified tumors occurring in the heart.
So thank you very much. It's really my pleasure to be here with you. Thank you for inviting me to this very interesting conference. Can you see my slide?
Yes.
Okay, for some reason I cannot enter the presentation mode. Let me try again. Okay, so, okay. Okay, good. So now we are going to talk of MDM2 CDK4 aberrant tumor of the heart, and the clinical approach to this group of disease. These are my disclosure that basically consist in intimal sarcoma. I asked to some pathology friend, and so far we do not have other mesenchymal tumor with MDM2 amplification and CDK4 alteration erasing from the heart. As was mentioned before by Elizabeth D'Amico, intimal sarcoma represent probably the most common primary malignancy of the heart. However, as anticipated, they are ultra-rare sarcoma, so with an incidence of less than 1 case per 1 million inhabitants per year. But according to the last publication by the French colleagues who look at the French database in which all sarcoma cases are centrally reviewed by an expert sarcoma pathologist, the incidence of intimal sarcoma is approximately 1.7 case per 10 million inhabitants per year. And if we take into consideration that heart intimal sarcoma represent slightly more than 50% of all site intimal sarcoma, we may think that the incidence of heart intimal sarcoma is approximately 1 case per 10 million inhabitants per year, which means 20 times less than angiosarcoma. So this gives us the proportion, the idea of how rare is the disease and how difficult it is to improve our knowledge and our treatment strategy in this setting. According to the French data, the peak of incidence is between 50 and 60 years, but of course we can see patients younger than that. We know that this tumor type that is listed in the last version of the soft tissue and bone WHO classification is more often an high-grade sarcoma, even though there are cases with a more indolent behavior. the morphology makes often differential diagnosis with other soft tissue sarcoma that can arise also from the heart, like angiosarcoma, leiomyosarcoma, and UPS not that easy. Of course, when MDM2 is amplified, differential diagnosis is much more easier, as the only other soft tissue sarcoma with MDM2 amplification is the deep liposarcoma, which usually does not arise from the heart and also show a different morphology. It is interesting to see that intimal sarcoma is not listed in the last version of the WHO classification of tumors arising from the thorax, including the heart. This is curious and probably related to what was mentioning today about some challenging in the definition of intimal sarcoma, which were there in the past, mentioned by Elizabeth. And the majority of intimal sarcoma probably falls into the group that there is called undifferentiated pleomorphic sarcoma. For us as clinician, these increase a little bit the difficulties, because not often patients are referred with the correct diagnosis, and for that reason, even in this case, centralized pathologic review, I think, is really mandatory. So intimal sarcoma probably more often arise from the left pulmonary artery, and they can misdiagnose with a thrombosis. Then we have cases with the tumor originating from the left atrium. And of course, also cases of intimal sarcoma that can arise from any other peripheral artery, like in this case, the left popliteal artery, even though those cases are less common. As mentioned this morning by Dr. Cusimano, it is usually commonly seen that while intimal sarcoma originates from the left atrium, angiosarcoma do arise from the right atrium. So I don't know which is the mechanical reason for that, but it's very uncommon to see an intimal sarcoma originating from the right atrium. With regard to treatment, as for all other soft tissue sarcoma, we may face three different scenarios. The case of local disease, in which we aim at curing the patient. The case of locally advanced disease that can be still treated with some kind of a combined local treatment, or the case with isolated lung lesion, in which there is a proportion of patients that can still be treated, and then patients with advanced disease with no room for surgical resection or definitive radiation therapy, in which we aim at prolonging survival and palliation. So in terms of localized disease, the standard approach is represented by the wide and block surgical resection, complemented by adjuvant or neoadjuvant radiation therapy, or definitive radiation when a residual, macroscopic residual disease is left behind. While even in intimal sarcoma, as mentioned before for angiosarcoma by Dr. Wagner, adjuvant, neoadjuvant chemotherapy cannot be considered a standard approach. Of course, when we have an intimal sarcoma originating from a peripheral artery, like in this case, to apply the general rule of a wide surgical resection is easy, even though probably more commonly than seen with other sarcoma, there can be neoplastic thrombus close to the main lesion. So this is something that we need to take into consideration. When we have cases originating from the pulmonary artery, surgical complete, macroscopic complete surgical resection can be achieved in some cases like this one, but the resection is always to be considered marginal. And so usually a complementary adjuvant radiation therapy, even when the post-surgical radiologic assessment is negative and the lesion was less than 5 centimeters, is advisable. And at least at our institution, we usually offer to any sites intimal sarcoma arising from the heart or close to the heart, completely resected, complementary radiation therapy. Then we have the cases, the more difficult ones, originating from the atrium. In these cases, at least at our latitude, pathologic diagnosis often is done after the surgical resection. So the surgical resection is not pre-planned and often is an emergency procedure. So even in the best scenario, the resection is marginal, and more often is a piecemeal resection. These, of course, correspond to a very high risk of local and of course systemic relapse, as we are talking of an high-grade disease in most cases. And for this reason, this is a situation in which there is a major need of complementing the surgical approach with neoadjuvant or adjuvant treatment. So even in this case, every time we can, for the age of the patient, comorbidities, and the extent of the primary presentation, we consider a radiation treatment, even when the lesion was less than 5 centimeters. And compared to other sarcoma types and other tumor location, similarly to what before discussed by Michael, by Dr. Wagner, we often offer to patient neoadjuvant or adjuvant chemotherapy. Of course, neoadjuvant chemotherapy is preferred, as we can, in that case, assess response to systemic treatment, while in adjuvant setting cannot be done. But also in adjuvant setting, often we discuss adjuvant chemotherapy with the patient, always specifying that this is not a standard option. So which data do we have to support the use of adjuvant chemotherapy? The data we have are limited and are basically derived from what we observe in terms of response to chemotherapy in the advanced disease, and what we have from this retrospective study, which was the result of an international initiative involving more than 15 sarcoma centers all around the world, who were asked to collect all the data available on MDM2 positive intimal sarcoma, among which also ART intimal sarcoma, looking at the activity of chemotherapy in patients with both localized and advanced diseases. The total number of patients with intimal sarcoma completely resected, treated in the localized phase was 24 out of 66 patients with the disease. 24 is a low number, of course, it's a small number, but I think that we can say that the proportion compared to other sarcoma types is a bit higher in terms of use of adjuvant treatment. So we look at the activity of anthracycline-based regimen, and in that case, for patients completely resected and treated with anthracycline-based regimen plus or minus radiation therapy, the median time to relapse was slightly more than a year, while the median overall survival was less than 6 months. But interestingly, there were a few patients alive with no evidence of relapse at more than 2 years. Also, this retrospective study showed that no cases of major cardiac toxicity, and for us this is an important information, as we know that doxorubicin can be cardiotoxic, and the use of this drug for heart sarcoma can be scaring, while from this study apparently doxorubicin does not represent a major problem. In terms of treatment for locally advanced disease, when radiation therapy can be used with a definitive intent, this can be an option. And here we have the case of a patient with really a bulky lesion who could not be clearly resected. The patient received 50 grade of radiation therapy. We could not increase the dose due to the location of the tumor, and remain with the disease control after almost a year. The follow-up for this patient is still short, but just to say that in terms of palliation, radiation therapy can be a good tool. This is another case of a patient who was partially resected, then was judged not potentially treated with a complete surgical resection. We decided to administer a chemotherapy, 6 cycles of epirubicin plus ifosfamide with a major response. This was complemented with definitive radiation therapy, and this patient is alive with no systemic neither local regional relapse after more than 10 years. And we have a few patients with the same clinical history. In case of advanced disease, when the disease presents with a few lung lesions that can be resected, the indication is for the surgical resection or radiation therapy ablation. While in case the disease presents with diffuse metastasis which cannot be resected, of course we need a systemic treatment. Then let's look before to cytotoxic agent. First we know that in case of intimal sarcoma arising from the vessels, and in particular those cases arising from the heart, the metastatic spread can involve several anatomic sites at the same time, like in this patient. The standard frontline treatment is represented by anthracycline. And again, going back to that study I was mentioning before, the retrospective one in which we look at both localized and advanced cases, looking at the activity of anthracycline in both localized and advanced patients, the overall response rate was of almost 40%, not very much different from what we see with anthracycline-based regimen in angiosarcoma. And the median progression-free survival for advanced patients, for the subgroup of advanced patients, was of 7.7 months. We also look at the activity of gemcitabine, and we know that gemcitabine can work in angiosarcoma, and we know the probability of a response is higher than 20%. Unfortunately, this was not the same we saw in intimal sarcoma, in which gemcitabine and also gemcitabine in combination with taxanes look to be not to have really a limited activity, with a less than 10% overall response rate and the median progression-free survival in advanced patient of around 3 months. In terms of cytotoxic agent, there are some reports, preclinical data on a mice model of intimal sarcoma published by the group of Patrick Shosky and also reports from retrospective series pointing out the activity of eribulin or of the potential, highlighting the potential role of tubulin agents like the one tested in the mice model, plocabolin. So this could be maybe an option when eribulin is available. For example, this is not the case in Europe, where it can be prescribed only for lipomatous sarcoma. In terms of anti-angiogenic, the retrospective study also showed a limited activity, a marginal activity of pazopanib of 12 patients with advanced disease. Only one achieved a response for a median progression-free survival of only 3 months. However, there are other case reports showing that in a few patients, anti-angiogenic can stabilize the disease or also achieve minor dimensional responses, like in this case, or in the retrospective study conducted among the ERTC sites, in which of 2 intimal sarcoma patients treated with pazopanib, one achieved a partial response. So this is not a very exciting systemic treatment, but can be an option to consider when we do not have other possibility, other medicine available. The background could be the known alteration of PDGF receptor alpha and beta that can be amplified or also mutated in a few cases. Then we have, of course, a very important interest in MDM2 inhibitors for MDM2 amplified and p53 wild-type intimal sarcoma. Data on this class of agents are still very limited. We can only refer to the presentation done by our Japanese colleague during ESMO 2021, which is not yet published in full. They tried the MDM2 inhibitor milademetan in a series of 11 intimal sarcoma. This is a small number, but again, considering how rare is the disease, there is not much more that we can do, at least outside international study. Almost all patients were treated in this study were wild type with regard to p53, and interestingly, the colleague in MDM2 amplified cases showed of 10 patients who were evaluable for response, 2 partial responses, and a few other cases that had a minor response. Again, underlying that this kind of compound can be an option for our patient. In terms of median progression-free survival, the results were not exciting, but there were a few cases which remain on therapy for more than a year. At the moment, I'm not aware of any specific plan to develop MDM2 inhibitor in the disease, but of course, would be great to know that there is an interest in this respect. In terms of other targets for advanced patients, we talked before about CDK4 and 6 alteration in the disease, but currently there are no case reports or retrospective data reporting on the activity of this class of agent as monotherapy or in combination, of which at least I'm aware. So my colleague participating to the conference today may have more insight than the one I have, but of course this would be another interesting road to explore. And there are also new data pointing out the amplification of TERT in intimal sarcoma. This is one of the paper, but it is not the only one, and so this could be another interesting option, even though this target cannot be directly targeted, at least for today. And with that, I think we try to cover, as much as we can what is available for the treatment of intimal sarcoma, but it's very clear that we need to work together if we want to make progress.
Thanks, Silvia. That was a real delight. Summary of all of the active agents and the data behind them. Clearly beneficial for at least the likes of me who are medical oncologists taking care of these particular patients. I will just want to remind the group that, please feel free to text in any questions to the chat functionality here. My first question, Silvia, is, in these patients, we often find that there's a very high likelihood of brain metastases that we see. How does that really impact sometimes even a diagnosis? How does that modify your treatment approaches in this patient population?
Okay, so in my experience, but again, we should work together to publish something. Radiation therapy is very effective in intimal sarcoma. We saw some pictures of lesion rising from the heart, but also for metastatic lesion, including the brain. Radiation therapy is really an option. And so considering these and also that there are patients with a more indolent behavior in which maybe anti-angiogenic can work, the presence of brain metastases should be always detected, but in our clinic does not prevent considering them for clinical studies or for active systemic treatment, provided that, of course, the brain metastasis is under control. Then I have a question for you. May I?
Yeah, absolutely.
So my question for you is if you have any information about the use of a CDK4 inhibitor in this particular setting. And the second one is a bit more a challenge, but I think that we need to go for this exercise. Which kind of study would you suggest in case anyone shows up saying, okay, I'm fine with investigating an MDM2 inhibitor in intimal sarcoma?
Yeah, for CDK4 inhibition, we've really gotten any impressive results in that particular direction. That data needs to be collated and published regardless. So that brings up an important point. The honest answer is I don't think we have a sense of what that response rate typically looks like or how effective it is. We did parse a few patients through these studies without much success. So I think like an international approach to collate data together on some available studies, agnostic of the agent use, but more homogeneously grouped together for the target would be really, really helpful in understanding it. So sorry, Silvia, I don't have a satisfying answer for it. So I have a couple of questions in the chat line. So Albie is asking, in Toronto, I'm aware of 2 patients who had a CDK4 inhibitor in an off-protocol setting, but none without response, but none with response. So there you have it. Albie's got a couple of patients that he's currently treating.
Okay, so my comment in this respect is that if they are treated outside clinical studies, would be very important to publish this case because in such a rare tumor, any case matters and can direct the treatment of the next patient that we see tomorrow in the clinic. So it's good to know, and we should, should be informed about the positive result.
Absolutely, I completely agree. I mean, especially with the kind of rarity we are dealing with here, every patient who is, treated either on or off protocol should make an active effort in trying to put those patients together. Again, I call out to Dr. Cusimanos and multiple researchers across the globe coming together underneath the Interact program. One of our key goals is to make sure that when you do treat patients with a particular molecular feature and are trying to target it, you log in that response in this international registry. So as time moves on, we would have a better way of really looking at those insights and B, publishing them periodically to update the community. But I'm hoping that Interact will be a very good solution for getting around this particular problem of using off-label use outside of the scope of clinical trials.
Yeah, and do you have any experience with immunotherapy in intimal sarcoma instead?
Yeah, so so one of the reasons I was asking about the brain tumor setting is that we've actually tried to kind of combine checkpoint inhibition and radiation in multiple patients. Generally, brain metastasis is supposed to have a dismal outcome with patients with any tumor type, but in intimal, we do see survivals that are, sometimes in excess of 12 months, and we're still looking at that particular aspect. Even with immunotherapy, and I don't have any solid data to stand on here, but anecdotally, there's been very good control of the disease and it remaining stable without progression, and some with actual reduction in size of the lesion as well. But we need to get that data together for publication. For sure.
Yeah, so as I also see in the chat that there are other cases, we should really try to put them together.
I think so. It certainly it certainly looks like it should be the next big Silvia Stacchiotti Excel sheet circulation that we normally do. Perhaps we should just get that done and do this as an international effort. We'd have really good sample sizes, and we'll be able to kind of get some of those questions answered, especially in the second setting of checkpoint inhibitors. There are also several trials that are attempting to target the combination CDK4 inhibition and also checkpoint inhibition. Also want to kind of call that out. These trials may be available closer to you. Please, if you have an interest in putting patients on it, connect with us at the cardiac tumor board that we host every month, and we're happy to coordinate and get you to a center close to you.
Yeah. And then, may I ask you a question? I already said that if there are no questions in the chat, but that we in Milan are very, prone to offer not only neoadjuvant, but also adjuvant chemotherapy in intimal sarcoma. I was wondering if you and Albi and Robin, I mean, those who are on the line are doing the same or not.
Robin, are you on?
Yes, I've been unmuted by the host, so that's always good. I agree, Sylvia. We tend to use chemotherapy, radiation, and surgery. As you know, even though the UK is maybe not the country that uses neoadjuvant adjuvant chemotherapy the most, I think for intimal sarcoma and cardiac sarcomas in general, we tend to go for tri-modality treatment. So I totally agree. And also, just to reiterate the point regarding publishing information, it's so important to get the information out there. I think I'm obviously having technical difficulties because I just sent a chat directly to Silvia rather than everybody about that. But I think it is important to publish, and even to publish the standard anthracycline chemotherapy doesn't work in a subtype. I think is very important information to have a benchmark for the use of drugs in very, very rare diseases.
Albie, do you want to comment on this?
Yeah, I think Sylvia, as always, you have hit the nail on the head that we are sitting on some of this data. Is quite novel. We should write it up. You're right. In Toronto, we almost always use neoadjuvant treatment for cardiac sarcomas, although we are not a big fan of neoadjuvant treatment for soft tissue sarcomas generally. We reserve radiotherapy only in selected cases, but usually is chemo then surgery. I guess it leads to my question to Michael earlier on. What I find very frustrating is that it's such a big undertaking to give them, highly toxic chemo. They go through heroic surgeries, and usually the effects are very modest at best. So, even using tools that we know, chemotherapies that we know, is there any value to give more chemotherapy towards the end? I know, we don't want to just keep using chemo. We're going to look at targeted agents and so forth. But our current status at the moment for these patients are so poor. And I wonder whether we can improve it just with the tools that we already have, right? Is something that I would really love to hear what other people think as well.
Sylvia, any comments on that?
No, I agree with Albie. The diseases overall and all heart sarcoma, honestly, are overall a frustrating, a very tough disease. Still, we have a few cases that could be cured. And this, to me, considering how terrible is the prognosis, is a reason in the lack of other option to try to give everything we have if the patient is young enough and fit enough. Also radiation. I have to say that we use a lot radiation in angiosarcoma and intimal sarcoma of the heart to try to complement surgery. This said, I agree. I share with you the frustration. I don't know if Dino uses do you use a chemotherapy, adjuvant in intimal sarcoma?
We try to. The reason I'm being a little sheepish about it is we don't have solid data, but the neoadjuvant AI is definitely the way that we have actually pushed our patients to really get them to cytoreduce as much as possible, and then they go to surgery. And post surgery, we've gotten to, just because Gemtax hasn't had that much of a great track record, we've started using more checkpoint inhibition in that setting. I would, however, say that it's really only meant for patients who really want to push the envelope and understand that we are on very thin ice with very limited amount of data, and we're extrapolating what we are seeing in the metastatic setting in that particular in that particular setting. And also to keep in mind, this is not like angiosarcoma. The recurrences don't happen really quickly. After surgical resection, they can take time. So it may seem like the checkpoint inhibitor is working, So it's really hard. I think we really do need a study in that particular space to really expand it out. We've offered it as a post-surgery option for many patients, but I can't say that there's enough body of data to support that particular approach.
Then I see a question in the chat, maybe.
Yes. Yeah. Silvia, so do you want to take that? There is no clinical trial available. What would be the preferred sequence post-anthracycline in this particular patients?
We have limited or no access to off-label users, so usually our second line is anti-angiogenic, pazopanib, or sometimes also sunitinib. And there are some patients who can stabilize. Then, according to the amount of metastatic disease, we try to use a lot radiation. While I had no good result, we tried with trabectedin, but we didn't see honestly, any real benefit in patient. I never tried trabectedin plus radiation to try to improve the sensitivity to radiation, honestly.
We've actually started to radiate along with checkpoint inhibition. We have a protocol now open for this particular purpose. Dr. Hassan here at MD Anderson in our sarcoma radon group is spearheading that particular activity as well. So that's another approach we have taken, especially in patients who are unresectable. Really looking to get that abscopal effect that Michael was talking about in this case with angio. I think intimal sarcomas are also a group of tumors where the checkpoint inhibition needs to be explored because of the potential for clinical utility in that setting. We had a couple of patients on, I think it was on one of Nita's trials that we had enrolled and did get bona fide partial responses in a combination dual agent checkpoint inhibition study as well. So
I think that to have those data on checkpoint inhibitor and CDK4 inhibitor activity would be important also to plan the next study. Yep. Because it looks to me that from the small Japanese series that the activity of MDM2 inhibitor is not such a great activity. It's better than nothing, but maybe combining the toxicity is not bad. Combining them together with a checkpoint inhibitor or a CDK4 inhibitor could be an option. And I don't think that we could plan 10 different studies. We should be ready with all the information we need to plan one right study and try to get the approval thanks to that study. So that's why I was asking which kind of study would you like to see?
Yeah, definitely the combination strategy is of a great deal of interest. We do know that the monotherapy approaches have limited utility, and considering the rarity of the tumor type and the limited opportunities we get to really treat these particular patients, a combination approach done in a very multi-institutional model would be the favored approach. We would be very interested in participating in any such effort going forwards. We have some sessions in the afternoon really trying to engage pharma in providing agents and backing such studies. We're finally at a point where internationally we are well connected and coordinated thanks to the efforts of many of the folks here on this call. It is therefore a good resource for the pharmaceutical industry to really utilize this network to move some of these agent, especially as combinations through a clinical trial in a international clinical trial in such a rare condition.
No, I agree. Then we should think of a trial that can include both patients with primary and metastatic disease, because both the setting do need an improvement, as Alvi was saying before. So,
yeah.
I'm going to make a comment as a surgeon. It's pretty easy to get a right-sided biopsy, very difficult to get these biopsies pre-op for the left-sided tumors, partly because it is on the left side. We do transatrial punctures, transseptal punctures. You need to get one cardiologist who does those, the congenital cardiologist, and get the transplant cardiologists to then get the biopsy. But so that's hard to get, number one. So it's hard to get that preoperatively for neoadjuvant therapy. And the second thing is that a lot of the left-sided patients come pretty far advanced in terms of their symptomatology. So it's pretty hard. But I'm really happy to hear everybody talking about international collaboration. That's really close to my heart as well. I really enjoyed your talk.
Yeah, RJ, that's a very important point. A lot of the unstable left-sided tumors will go through surgery up front because there's no time to wait around, and that definitely needs to be incorporated into the design as well. So this actually brings up an important point that these studies cannot be considered, they require multi-institutional participation, but they also require multidisciplinary participation, particularly from surgeons in understanding this complex workflow of really managing the biopsies, when should surgery actually take place. If we are going to design one study that includes both the advanced and the earlier stage patients, doing it in a multidisciplinary fashion with both surgical oncology, radiation oncology, and med-onc at the table would be really helpful.
Hopefully next year we'll get the Interact project going and we can talk better about that in the future.
The other interesting thing I want to kind of pick both Silvia, Robin, and I don't know if Paul's on the call. I do know if Alex Lazarus is here. In terms of molecular profiling of these tumors on a systematic basis, especially in intimal sarcomas, we've been sort of kind of focusing a lot on the MDM2 amplified patients. I know the other group is a minority. Is there a case to be made in profiling all of these patients, considering the complexity that Dr. D'Amico was presenting? And Liz, I don't know if you are on the call as well. Do you want to weigh in on this? So please unmute and let us know what you think.
So my comment, while maybe Alex and Paul answer the question, is that the lack of the intimal sarcoma entity in the WHO book of our tumor does not help at all, because if you have MDM2 amplification, okay, it's easy. But what about those UPS of the heart without MDM2 amplification that are not even called intimas? I mean, there is in addition to the rarity, there is also still some work to be done in the classification and the improvement of the WHO book of the heart and thoracic tumor.
Liz, Alex, any comments on that?
I mean, I definitely agree that there can be improvements in the classification in the cardiac book. Both the vascular intimal sarcomas and the cardiac ones are the same thing. And, even if they don't have MDM2 amplification, they have other things that can be amplified that mimic the same effect as MDM2, maybe not as targetable with drugs, but they behave as a group very similarly, regardless of their genomic heterogeneity. And I think we need to do some more detailed studies to find out exactly how these tumors differ when they don't have MDM2 amplification, how that's going to affect their behavior in response to therapy, rather than saying, oh, they're entirely separate tumor type. I think they should be all studied together as one entity to distinguish what we really need to do to treat these properly.
But Elizabeth, you know that I like very much talking with the pathologist. May I ask you a question?
Yes.
Okay. Do you think that UPS of the left atrium do exist, or they are all intimal sarcoma?
They're all intimal sarcomas.
Okay.
Yeah. Yeah.
Okay. And none of them can be misdiagnosed with other type of sarcoma. I mean, which other sarcoma type can originate from the left atrium?
Pretty much nothing that originates in the left atrium are intimal sarcomas, very rarely angiosarcomas. Occasionally synovial sarcomas will occur there for some reason. And then like the sarcomas that have heterologous differentiation, like the quote unquote rhabdos and osteosarcomas of the heart, but they're probably just intimal sarcomas with heterologous elements, but they haven't really been well studied. So I can't say for sure that they're not their own thing. And there are things that imitate UPS in the heart. Like I've seen metastatic sarcomatoid germ cell tumors in the heart that very well imitate a UPS, and that has to be very carefully ruled out clinically in the patients. So there are mimics that are not actually primary in the heart, but sometimes as cardiac primaries.
And how many UPS originating from the pulmonary artery are not intimal sarcoma?
Yeah, they're all going to be intimal sarcomas. Whether or not they have MDM2 amplification, they behave the same as the ones that do have MDM2 amplification. And so they really are all intimal sarcomas.
Okay, thank you. These should be very much clearly stated everywhere.
If only everyone agreed. It's hard to reach consensus among us. We all have too many opinions.
So Silvia, in that regard, the non-MDM2 patients, the smaller subset as it may be, in terms of clinical behavior on the available existing therapies or the kind of trials that you would consider, obviously the trials are going to be kind of different, but for the cytotoxic therapies, in your paper, you chose to focus on the MDM2 amplified ones, probably as a way of eliminating heterogeneity more than, or do you really feel that MDM2 is so different from the non-MDM2 intimal sarcomas? What are your thoughts there?
No. The reason for selecting only for excluding MDM2 negative cases was to try to improve the quality of a retrospective study, because there are already so many criticisms that or you centralize all the pathologic diagnosis, or otherwise it gets very difficult to be sure that we are talking of the right tumor. No, in the clinic, in my experience, there are no difference. I mean, I don't know with MDM2 inhibitors, but in terms of clinical behavior or, you know, sensitivity to doxorubicin, I cannot remember any particular difference. And honestly, I think that they respond really a lot to doxorubicin. A lot means more than what we see with the soft tissue sarcoma in general.
Yep.
I'd agree with that, Silvia. That's been my observation as well, that there isn't really a difference in terms of response to systemic therapies.
Robin, do you guys use checkpoint inhibitors in this particular subset at all?
Yeah, really good question. I think the sort of the answer in terms of the UK is no, because it's virtually impossible to access drugs off license in the UK in general, unless somebody has private insurance coverage or is very rich. Having said that, we do have access to compassionate access checkpoint inhibitors, and have been successful in applying for patients with angiosarcoma in particular. But I've not yet applied for a patient with intimal sarcoma, although we do have a number undergoing conventional therapy right now. And again, I suppose this comes back to the point regarding publishing data on these rare subtypes, because anything like that will help an application for compassionate access. So the short answer is no, but we try to.
Yeah, the same is for us. You know, for so rare cases, it can be that we are allowed a compassionate access, but this is impossible if there are no data published. We never have an insurance or another way unless the patient decides to pay from his own pocket, out of his pocket. Anyway, and this is right, the reason for publishing even the single case report, provided that the diagnosis is very well you know, refined, and we are sure that we are talking of the true intima sarcoma.